Assalamualaikum and good day. This is part 2 of the lecture Valvular Heart Diseases, Rheumatic Fever and Rheumatic Heart Disease. My name is Dr. Mardiana Abdulaziz from the Department of Pathology, UITM. So at the end of this part of the lecture, you should be able to describe the etiology, pathogenesis, morphology and clinical manifestations, as well as complications of rheumatic fever, and also to describe the pathogenesis, morphology, and clinical manifestations and complications of chronic rheumatic heart disease. And skill-wise, you should be able to identify the morphological features of acute and chronic rheumatic heart disease. So to start off with rheumatic fever and rheumatic heart disease, what is rheumatic fever? Rheumatic fever is an acute, immunologically mediated, multi-system inflammatory disease occurring which is typically 2 to 3 weeks after an episode of group A streptococcal infection. Rheumatic heart disease, in particular, refers to the cardiac manifestations of rheumatic fever. Sometimes this can be used to describe the cardiac manifestations in acute rheumatic fever, but more often rheumatic heart disease implies the presence of chronic rheumatic heart disease, which are valvular changes seen many years after rheumatic fever has subsided. So what is the pathogenesis of rheumatic fever? So rheumatic fever is an immunologically mediated reaction. So in this case, the antibodies against group A streptococcal molecules cross-react with host antigens, including myocardium, cardiac valves, and or joints, for example. So following an infection by streptococcus, typically this is streptococcal pharyngitis, but theoretically infection by streptococcus even at other sites such as the skin may also produce the same reaction. So when the infection happens, then the body mounts an antibody response towards the antigen. But in the setting of formation of rheumatic fever, the same antibodies unfortunately cross-react with host antigens. So this results in activation of complement and Fc receptor-bearing cells, also cytokine-mediated inflammatory responses, and these give rise to tissue injury and then the clinical manifestations of rheumatic fever. So for example, cross-reaction between the antibody and the host myocardium and the host cardiac valves give rise to carditis, and antibodies which cross-react with joint tissue will lead to arthritis. However, only a small proportion of individuals who are infected by streptococcus will develop rheumatic fever, only up to about 3%. So it is believed that genetic susceptibility may play a role in terms of making someone more susceptible to the development of these cross-reactive immune responses. The onset of symptoms of rheumatic fever are typically seen 2 to 3 weeks after the streptococcal infection. So in this case, streptococcal pharyngitis being the most common. So why 2 to 3 week delay in symptom onset? This is because 2 to 3 weeks is the characteristic duration required to generate an immune response. So after about 3 weeks, when the patients start developing showing features of rheumatic fever, at this point in time, the streptococcal antigen may no longer be demonstrable within the patient's tissue. The antigen itself may have been cleared, but it is the antibody that is mounted against that antigen which is now causing injury to the host tissue. So what are the diagnostic criteria for rheumatic fever? The diagnosis requires, number one, this is a must-have, and that is evidence of recent streptococcal infection. So it could be either in the form of a positive throat culture during the episode of streptococcal pharyngitis, or if it's a little bit later, maybe elevated anti-streptococcal antibody titer, such as anti-streptolysin O titer or ASOT. So this is a must-have. Okay, so point number 1 is a must-have, and this evidence of recent streptococcal infection is seen along with either 2 or more major Jones criteria or 1 major and 2 minor Jones criteria. So it is a combination of this plus this or this plus this, which makes the diagnosis of rheumatic fever. So what are Jones criteria for the diagnosis of RF? So I've mentioned Jones criteria. Jones criteria can be divided furthermore into major and minor criteria. So major criteria, there are 5 of them. So this is a multi-system disorder, if you remember that I mentioned earlier. So the manifestations may involve organ systems such as the joints, the heart, the skin, as well as the nervous system. So the first major criteria is migratory polyarthritis of large joints. In migratory polyarthritis means inflammation of multiple joints, okay? And this tends to affect the larger joints of the body. So, for example, knee joint, ankle, shoulders, elbow. More than one joint may be affected at any given time, and they tend to move, right? So let's say if it starts at the shoulder joint, and then the arthritis will migrate and start to involve the elbow joint, for example, or maybe starting off with the knee joint and then migrate and involve the ankle joint, okay? So that's migratory polyarthritis. The second major criteria is carditis. So carditis, which is referring to the inflammation of the heart, may affect any layer of the cardiac tissue or cardiac wall. So it can be the endocardium, myocardium, or the pericardium. If there is involvement of all 3, then the terminology used is pancarditis. It can give rise to some clinical manifestations such as arrhythmia and pericardial rub. Subcutaneous nodules is another manifestation. So you can see that this appears as a lump just under the skin. And erythema marginatum is an abnormality or a rash of some sort occurring on the skin. So we can see that there are multiple red lesions with a central pallor. So it's pale in the middle and much redder all around. So this is erythema marginatum. Okay. And the 5th major criteria is Sydenham chorea.
Real slow. Okay, now turn around. Okay. Can you turn around and walk back now? Thank you.
Notice the abnormal jerky movements or uncontrollable movements seen in this case.
Sarah's 83, right? Okay. Do you know how did they measure?
83 pounds.
Wow. Sarah's 83, right? Okay. Do you know how did they measure?
So that short video illustrates what Sydenham chorea looks like. The abnormal movement may subside, but it can take even longer than a year in certain cases. In terms of minor criteria, this includes fever, arthralgia, ECG changes, and also elevation of acute phase reactants such as CRP and ESR. Now let's have a look at some pertinent morphological changes that can be seen in rheumatic fever carditis. So this is inflammation of the heart or involvement of the heart in an episode of rheumatic fever. So the underlying pathology is that there will be discrete inflammatory foci in the tissues. So the inflammatory foci are called Aschoff bodies. I'll show you what they look like in a moment. And these inflammatory foci, or these Aschoff bodies, can be found in all three layers of the heart. And when it does involve all three layers of the heart, then we call it pancarditis. So this manifests as pericarditis. When you have inflammation of the pericardium, then you get pericarditis. And morphologically, what you see is this yellowish fibrinous material coating the outer surface of the heart. And this yellowish shaggy material can adhere to the parietal pericardium, and it can give rise to pericardial rub. Myocarditis is inflammation of the myocardium, and what it can do is sometimes it can result in dilatation of the heart. And valvular manifestations valvular involvement can give rise to the presence of vegetations, or sometimes referred to as verrucae. So these are small vegetations, small sort of yellowish fiber material, which are attached to the edges of the cusps. So microscopically, probably the most important feature to know of will be Aschoff body. So Aschoff body is pathognomonic for acute rheumatic fever, and an Aschoff body is composed of activated macrophages. Okay, so these are activated macrophages, and they are also termed NH-cow or caterpillar cells. Okay, in this particular setting. Okay, so why is it called caterpillar cells? It's because the chromatin within the nucleus actually condense in a manner that makes it look like a caterpillar. On top of that, you get collections of T lymphocytes, so you can see some lymphocytes at the edges, scattered plasma cells, as well as the presence of fibrinoid necrosis. So this is pathognomonic. So if you see an Aschoff body, then you know the patient has rheumatic fever. So clinically, how do patients present? Easy way to think about it is as per Jones criteria. Okay, so the Jones criteria is quite a clinical thing anyway, so there are the major and the minor criteria in there. So they are the ones that are detected as clinical manifestations. So the first one is carditis. So carditis, as we mentioned earlier, is inflammation of the heart, so perhaps even up to all layers of the heart, pancarditis. So patients can manifest as pericardial friction rubs, tachycardia, arrhythmia. If the carditis is severe, patients may develop cardiac dilation, and particularly if this involves the left ventricle, as the pupillary muscle tethers the mitral valve to the left ventricle. This results in the mitral valve being pulled apart, so the orifice becomes larger, and that leads to mitral valve insufficiency, and perhaps even heart failure. Carditis causes death in about 1% in the setting of rheumatic fever. So patients can also present with findings relating to polyarthritis, so the joints will be red and swollen, and obviously skin changes, subcutaneous nodules, incident chorea can also be a manifestation in itself. Okay, so that is rheumatic fever, also sometimes referred to as acute rheumatic fever. So next I would like to move on to the chronic rheumatic heart disease. Chronic rheumatic heart disease develops many years after the initial acute rheumatic fever. So many years up to even decades after the initial acute rheumatic fever. As one of the causes for acquired valvular abnormality, it can cause both stenosis or regurgitation, but stenosis is definitely more common. Mitral valve involvement alone is seen in about 70%. Mitral and aortic valve involvement is seen in another 25%. Tricuspid valve and pulmonary valves are generally uncommonly involved in chronic rheumatic heart disease. And of all the potential abnormalities that can happen, mitral valve stenosis is the most common abnormality seen in chronic rheumatic heart disease. Let's have a look quickly at the pathogenesis of chronic rheumatic heart disease. So first of all, it is important to know that patients who had acute rheumatic fever are generally at a higher risk of disease reactivation with subsequent infection. So every time the patients get reactivation, the carditis tends to worsen. What happens then? So carditis is inflammation. So as we mentioned earlier, rheumatic fever has inflammatory foci, Aschoff bodies. So these acute inflammatory foci, these foci of Aschoff bodies, they undergo organization and scarring, and thus resulting in fibrosis. So the damage is cumulative. So every time the patient gets another reactivation, gets another episode of reactivation, then every time the patient will accumulate more and more damage to the valves and the heart tissue. So fibrosis that occurs often involves the valve cusps and leaflets, and as I mentioned earlier, mitral valve stenosis is the most common abnormality in this setting. So what does mitral valve stenosis look like? There are a few characteristic features of mitral valve stenosis in rheumatic heart disease. Number one, there is often leaflet thickening. So individual leaflets of the mitral valve are thickened. There is commissural fusion and thickening. So this is fusion right here. Okay, fusion right here. You can see commissural fusion and thickening as well. Thickening and shortening of chordae tendineae, okay, such as demonstrated here. You can see some thickening of the chordae tendineae here. Calcifications are often seen, as shown in this image on the right. So you can see these yellowish deposits which represent the calcification. And all of these combine together to give rise to this appearance of fishmouth or buttonhole stenosis. So what are the clinical manifestations and complications of mitral valve stenosis? So this is a normal heart where the blood should flow from left atrium into the left ventricle. In mitral valve stenosis, there is a narrowing of the orifice of the mitral valve, and this gives rise to several manifestations which relate to the degree of stenosis. One of the potential complications is the development of infective endocarditis and the subsequent complications of infective endocarditis. Because the mitral valve is narrowed, then there will be turbulent flow across the narrowed orifice, and this can manifest as murmur on auscultation. If the patient develops infective endocarditis, then the patient may also present with clinical manifestations of infective endocarditis. So with narrowing of the lumen, there will be a reduction in blood flow into the left ventricle. So what happens is that there will be overload in the left atrium, and this results in left atrial dilation. Left atrial dilation predisposes to atrial fibrillation and also mural thrombosis. So if the patient has atrial fibrillation, they may complain of palpitations. If the patient develops mural thrombosis, then it is important to remember that mural thrombi can give rise to a variety of systemic embolism such as stroke. So when there is a reduction in the flow of blood into the left ventricle, this will lead to decreased diastolic filling. This leads to impaired myocardial contractility as well as reduced cardiac output. And reduced cardiac output can subsequently contribute to dyspnea, particularly on exertion. With mitral valve stenosis, there will be back pressure into the pulmonary circulation, which gives rise to pulmonary hypertension, and this can put strain onto the right side of the heart and causes right heart failure. Increase in pulmonary venous pressure also leads to interstitial edema in the lungs, which can contribute to dyspnea and reduce effort tolerance. So before we finish, let's just have a quick review of the timeline of rheumatic fever developing into rheumatic heart disease. So at the very start, the patient gets streptococcal infection. So sore throat would be a common manifestation, and this may be supported by evidence of infection, such as a positive throat culture. So 2 to 3 weeks is the characteristic duration required for the generation of immune response. So after 2 to 3 weeks, then this is the onset of the rheumatic fever, which is a multi-system organ involvement such as carditis, arthritis, etc. So at this point in time, the organisms may no longer be present, but we may be able to demonstrate a rising titer, such as the ASOT. So while between the streptococcal infection and the onset of rheumatic fever only take a couple of weeks, but it takes years and years and years before the patient develops chronic rheumatic heart disease. And this occurs via cumulative injury and healing by fibrosis, which distorts and destroys the valvular structure. So the patient has a permanent valve damage with or without complications, and the most common manifestation is mitral valve stenosis. So that marks the end of part 2 of this lecture, which is rheumatic fever and rheumatic heart disease. My references were Robbins' Basic Pathology and Underwood's Pathology. Thank you.